Let us begin with an introductory question to this topic. You are evaluating a female patient with an audible systolic murmur. To confirm your clinical suspicion, you ask her to firmly grip your hands. This maneuver reduced the murmur intensity. Which of the following conditions is she most likely suffering from? Mitral regurg, or stenosis, ventricular septal defect, aortic regurg, or aortic stenosis. For now, let me give you the correct answer, and then we're going to add more information as we go on, and you're going to learn more about these topics. The correct answer is aortic stenosis. This means that hand grip reduces the intensity of murmurs of mitral regurg, mitral stenosis, VSD, and aortic insufficiency. Again, as we're going to see later. Before I go any further, let us first review some important basic concepts. Increased blood flow through defective valves increases the intensity of their murmurs. Modulating preload and afterload will increase or decrease intensity of murmurs. We do, however, need to know what defects increase and what defects decrease their intensities after we modulate the preload and afterload. What are some important maneuvers that decrease the preload? These are Valsalva, standing, hypovolemia, tachycardia, and use of vasodilators such as amyl nitrite. Maneuvers that increase preload include squatting, passive leg raising, increased ECF volume, and bradycardia. Why does Valsalva decrease preload? The Valsalva maneuver is performed by moderately forceful attempted exhalation against a closed airway. It's usually done by closing one's mouth, pincing one's nose shut while pressing out as if blowing up a balloon. There are a few phases in the Valsalva. The first phase is a rise in the blood pressure in the chest that will force blood out of the pulmonary circulation into the left atrium. This in turn causes a rise in the stroke volume. However, within 10 to 20 seconds, and as a result of high pressure in the chest, the first phase is followed by reduced venous return to the heart. Of course, as you can tell, the reduced venous return sequentially drops the preload of the right and then the left ventricle. So, when we say Valsalva reduces the preload, it specifically relates to this second stage. Now, why does bradycardia increase the preload? Because it increases the length of diastole and allows for more filling time. Why does squatting increase preload? Squatting increases systemic venous return by pressing on the big veins, but it also raises the afterload because with prolonged squatting, the lower arteries, such as femoral arteries, are compressed. What maneuvers decrease afterload? The main ones are hypovolemia and use of vasodilators such as amyl nitrite. Maneuvers that increase afterload include squatting, hand grip, and use of alpha 1 agonists and beta-2 blockers. Example of alpha-1 agonist is phenylephrine. Example of beta-2 blocker is propranolol. So, squatting does two things. Increases both the afterload and the preload. Why does beta-2 blockers increase the afterload? Because they block the beta receptors that normally dilate the vessels, in particular in our striated muscles. Finally, what are some must-know murmurs wherein application of the former maneuvers may clinically become important? These are mitral regurg, mitral stenosis, aortic regurg and stenosis, VSD, ASD, and hypertrophic cardiomyopathy. Let us look at the summary of the effects of increasing afterload on murmur intensity in various valvular pathologies. Valvular pathologies that increase their murmur intensity with increased afterload include aortic insufficiency, mitral insufficiency, mitral stenosis, and ventricular septal defect. Note that this only applies to early stages of VSD, when there is a left to right shunt and the patients are not yet presented with cyanosis or Eisenmenger Syndrome. Defects that decrease their murmur intensity with increased afterload include aortic stenosis and hypertrophic cardiomyopathy. What is the most common cause of sudden cardiac death? The answer is hypertrophic cardiomyopathy. What is the difference between hypertrophic cardiomyopathy, HCM, and hypertrophic obstructive cardiomyopathy, HOCM? In essence, there is no difference between the two, functionally and genetically. However, obstructive hypertrophic cardiomyopathy blocks the ventricular outlet and the other one will not. Both of them present with hypertrophy of the heart muscles and in particular the septum that separates the left and right ventricles from each other. What will happen to the murmur intensity of hypertrophic cardiomyopathy with decreased preload? It increases. Pathology of HCM includes presence of a thick and bulged out interventricular septum that potentially may make the outlet passageway from the left ventricle narrow. Under condition of low preload, the diameter of the ventricular chamber decreases and the thickened septum makes the outlet much narrower. This will intensify the murmur as blood tries to squeeze itself through a narrow channel. In contrast, when the preload increases, the septum is pushed away from the aortic valve orifice and blood can exit more smoothly. Hence, the intensity of murmur decreases with high preload. Of course, cardiac physiologists love to make all these stories quite often more complicated for medical students, and they often introduce some jazzy terms such as Venturi effect into the mix. Let us see how we can make once for all this story simple and memorable. As I said, protrusion of a thick upper ventricular septum in HOCM reduces the left ventricular outlet orifice. Now blood that tends to flow through a narrow outlet speeds up and as a result rumbles, whooshes, and makes a murmur. Meanwhile, high flow rate and low pressure flow through the narrow outlet induces a suction effect on the adjacent areas. The jazzy name for all these is the Venturi effect. So what will that suction effect do? It draws the anterior leaflets of the mitral valve towards the septum and further decreases the diameter of the outlet tract. Meanwhile, as a result of dragging the anterior mitral leaflet into the ventricle, it induces a functional mitral insufficiency, a mitral regurg-like situation. Therefore, the systolic murmur in HCM is due to two important must-know factors: high flow rate through a narrow outlet plus mitral regurgitation. The narrowed outlet will make the HOCM analogous to aortic stenosis, while dragging effect of the mitral's leaflet makes it analogous to mitral insufficiency. To make it simple, HOCM has both an aortic stenosis-like and a mitral regurg-like effects. To add one more jargon to the list of must-know terms, the outlet stenosis and mitral insufficiency of HCM is known as dynamic or flow rate dependent, and it is only functionally similar to aortic stenosis or mitral regurgitation. This diagram shows the relevant attributes of the Venturi effect. To make it simple, fluids in dilated tubes have a low velocity and high pressure. However, as they squeeze through a narrow outlet, they speed up and convert all that pressure into higher flow rate with sound and vacuum-like effects. A good analogy is the analogy of a water hose with adjustable nozzle head. A narrow nozzle will project water forward more forcefully and meanwhile produces more sound effects. Now, to relate all this to HCM, a septum that obstructs the left ventricular outlet will cause a systolic murmur as blood passes through a narrow outlet and the aortic valve. Meanwhile, it induces a suction effect and dynamic mitral insufficiency, and as a result, back regurgitates some blood into the left atrium as well. This also causes a compounding systolic murmur. So why do we see a jet engine in this diagram? Just to not forget about the suction effect of the Venturi phenomenon and the mitral insufficiency that it causes. So HOCM has two must-know functional dyads: the aortic stenosis and mitral insufficiency. Both USMLE and COMLEX exams, and more so the USMLE, love to test the abilities of students to discern between these dyads. What is the genetic cause of hypertrophic cardiomyopathy, after all? Well, this is an autosomal dominant effect. Mutation causes defect in sarcomere units, the proteins, mainly beta-myosin protein or units. As a result, there is disruption of the contractile units in the heart. Let us compare and contrast hypertrophic obstructive cardiomyopathy with aortic stenosis and mitral regurgitation. HOCM and aortic stenosis resemble each other because both cause obstruction of outflow from the left ventricle. Both produce systolic murmurs, and in both intensity of murmurs decreased with increased afterload. Also, clinical picture of both includes syncope. But HOCM causes a functional or dynamic stenosis, whereas the stenosis of aortic stenosis is fixed. And here is the differential point where the test makers love to drill you on the exams. In HOCM, low preload conditions intensifies the murmurs, whereas low preload conditions drop the intensity of AS. With regard to HOCM and mitral regurg, both present with mitral valve insufficiency. Both conditions cause systolic murmurs. Intensity of murmurs in both increase with low preload and decreases with high preload. Again, here is where the differences come into picture. The mitral insufficiency of HOCM is dynamic, whereas the mitral insufficiency of prolapse is fixed. High afterload decreases the intensity of murmur in HCM and increases it for the prolapse. In contrast, low afterload increases the murmur of HCM due to Venturi effect, whereas it decreases the intensity of mitral valve prolapse murmur. As I said before, HOCM causes dynamic outflow obstruction. What is the description of dynamic flow obstruction? This is left ventricular outflow obstruction that depends on the ventricular volume and flow rate during systole. What is the effect of isoproterenol administration on the left ventricular volume, and how does this affect the intensity of murmur in HOCM? Isoproterenol has both beta-1 and beta-2 agonistic function. The beta-1 agonistic function causes positive inotropism. It increases the contractility of the heart, and as a result it increases the ejection fraction, and as a result it drops the ventricular volume, or end systolic volume to be more exact. As a result of increased contractility and increased flow rate through the narrow outlet and the Venturi effect, the murmur gets louder. What is the effect of atenolol administration on left ventricular volume, and how does this affect the intensity of the murmur in HOCM? Atenolol has beta-1 antagonistic function. It is a selective beta blocker. It causes negative inotropism. It reduces the contractility. As a result, it decreases the ejection fraction. And because of that, it increases the ventricular volume. As a result of increased volume, the thickened part of the interventricular septum is going to be pushed away from the outlet area, and the dynamics of flow out of the ventricle will return back to normal. Therefore, atenolol reduces the intensity of murmur in HOCM. What is the effect of phenylephrine administration on left ventricular volume, and how does this affect the intensity of murmur in HOCM? Phenylephrine has alpha-1 agonistic function. It's a very strong alpha-1 agonist. It increases afterload, and as a result of increasing the impediment to the flow out of the left ventricle, the ejection fraction is going to go down. Ejection fraction goes down, more blood stays in the heart, and ventricular volume increases. As a result of increased volume, the thickened part of the interventricular septum is going to be pushed away from the outlet area. Left ventricular outflow tract obstruction and gradient will drop, and the dynamics of the flow will return back to normal situation. Therefore, intensity of the murmur decreases with phenylephrine administration. What is the effect of prazosin administration on left ventricular volume, and how does this affect the intensity of murmur in HOCM? I want you to know that currently prazosin is not used much in clinical settings for evaluation of HOCM. Amyl nitrite is a drug of choice for this purpose. Well, prazosin has alpha-1 blocking effect. You block the alpha-1s, you're going to dilate the vessels. You dilate the vessels, you decrease the afterload. You decrease the afterload, you increase the ejection fraction. You increase the ejection fraction, you decrease the ventricular volume. As a result of increased flow through a narrow outlet, because of increased outlet gradient, there is an augmented Venturi effect, and the murmur intensity increases. Therefore, prazosin increases the murmur intensity in HOCM. What is the effect of amyl nitrite administration on left ventricular volume, and how does this affect the intensity of murmur in HOCM? Effects are similar to prazosin. It decreases the afterload, increases ejection fraction, decreases ventricular volume, and as a result of increased flow through the narrow outlet, there is an augmented Venturi effect, and the murmur intensity increases. And again, by augmented Venturi, I mean two things. First, flow through a dynamically narrow chamber. Secondly, the induced mitral regurgitation because of the suction effect that the Venturi effect will have on the anterior leaflets of the mitral valve. So what is the effect of Valsalva maneuver on left ventricular volume, and how does this affect the intensity of murmur in HOCM? Valsalva decreases preload. It decreases ventricular volume. The outflow passageway gets more obstructed, again, due to the thick interventricular septum. As a result, the murmur intensity increases because blood has to pass through a narrow outlet. Hence, Valsalva increases the murmur of HOCM. What is the effect of hand grip maneuver on left ventricular volume, and how does this affect the intensity of murmur in HOCM? Hand grip increases afterload. Ejection fraction goes down. As a result, ventricular volume goes up. As a result of increased volume, the thickened part of the interventricular septum is pushed away from the outlet area. Left ventricular outflow tract obstruction and gradient, as a result, will decrease, and the dynamics of the flow will return back to normal. Therefore, intensity of murmur of HOCM decreases with hand grip maneuver. Your patient is a 31-year-old woman who is diagnosed with mitral prolapse. Auscultation of her heart is significant for an audible mid-systolic click. Which of the following options is a more likely auscultation finding if she moves from sitting to a standing position? The click gets closer to the S1 and the murmur duration gets longer. Just to know, standing position will reduce venous return to the heart. It decreases preload. Reduction in preload will reduce the sloppiness of the chordae tendineae. As a result, the valve prolapses earlier and click gets closer to the S1. Since prolapse happens earlier, it allows for more time for blood to keep on regurgitating into the atrium. Therefore, the post-click murmur duration increases. Again, it increases because we have more available time for backward flow. Name 3 important conditions and/or maneuvers that move the click of the mitral valve prolapse closer to the S1 position, to the first sound position. These are conditions that decrease the preload: Valsalva maneuver, hypovolemia, and vasodilators. Name 3 conditions or maneuvers that move the click of the mitral valve prolapse closer to the S2 position. Any condition that increases the preload can do it: squatting, increased blood volume, and bradycardia. The picture on top is a good mnemonic to remember that when the volume is small in the left ventricle, the click stays closer to the smaller number, the number 1. But the murmur has more time, more duration. It has all the space from the click position up until the S2 position to produce murmur for us. In contrast, when the volume increases, the click is pushed farther away from the S1 and closer to the S2. Therefore, the murmur duration decreases because we have less time available for the murmur. So, to summarize, what will happen if you decrease the preload? The click gets closer to the S1. What conditions will cause the click to get closer to the S1? These are standing, Valsalva, amyl nitrite administration, administration of beta agonists, prazosin administration, and inspiration. I want you to know that the volume of left ventricle decreases with inspiration. In contrast, when we increase the preload, the click gets closer to the S2. What conditions will do this? Squatting and hand grip, increase the blood volume, bradycardia, beta blockers, phenylephrine administration, and expiration. Again, remember, with expiration, the volume of the left ventricle increases. So, inspiration increases the volume of right ventricle and decreases the volume of the left ventricle. Again, this is the mnemonic and analogy that I want you to have in mind so that you never forget that increased volume of the left ventricle will push the click farther away and closer to the bigger number, which is the number 2, S2. Increased ventricular volume kicks back the click. You are observing a 5-year-old child with a history of Tetralogy of Fallot. While praying with a few other children in the patient receiving room of your office, the child's lips turn blue and he stops his play and squats for almost 20 seconds and then resumes his play. You notice that his lips are no longer cyanotic. What is the most likely physiological mechanism of reduced cyanosis in this child? When I look at this question, option A and B, increased or decreased vascular resistance in systemics, and option C and D, that are increased pulmonary or decreased pulmonary resistant, look at 2 pair opposing diets, and it seems one of them One of the members of each pair should be the correct answer. Therefore, at least test the strategy will tell me not to focus my energy on option E. But which one is the correct answer? The correct answer among A, B, C, and D is between A and B, and between A and B, the correct answer is increased systemic vascular resistance. So why does squatting cause relief of cyanosis in tetralogy? With prolonged squatting, the lower arteries, such as femoral, are compressed. This maneuver raises the afterload, or systemic vascular resistance. As a result of increased TPR, or the afterload, the left ventricular pressure also increases. The rise in left ventricular pressure acts as an impediment to free flow of the right ventricular volume through the ventricular septal defect into the left ventricle. This increases the pulmonary flow and allows for more oxygenation of the blood. And this is what those children love to gain from squatting. So again, this diagram explains it all. Increased systemic pressure is an impediment to the flow into the systemics. Therefore, less blood can pass into the systemics and more can push itself through that narrow orifice of the pulmonary valve into the lungs, and therefore more blood gets oxygenated and the patients present with a lesser degree of cyanosis. Patients with VSD are presented with systolic murmur. What is the effect of hand gripping on the intensity of murmur in these patients? Hand gripping increases systemic afterload. Less blood can enter the aorta. More is poured onto the right ventricle. Therefore, the murmur intensity gets louder. In a patient with VSD, increased systemic afterload diminishes intensity of systolic murmur. What is a reasonable explanation for this finding? How can you help me with this paradox? I don't want to contradict what I said earlier to you. Help me. How can you help me? The answer is the patient most likely has Eisenmenger Syndrome. This is the latest stage of VSD. Increased systemic pressure reduces the right to left pressure gradient this time. Right to left pressure gradient. And as a result, right to left flow. Therefore, the murmur is reduced. Remember, in the Eisenmengers, we have a right to left shunt. These patients present with serious cyanosis. Patients with atrial septal defect, ASD, may present with a systolic murmur. What is the explanation for this finding? This time, increased flow to the right heart and ultimately through the pulmonic valve. So it is best heard at the pulmonic area, the upper left sternal border. So the murmur of ASD is the murmur due to passage of a higher volume of blood through the pulmonic valve. I want you to know that the heart valves are normal in the ASD. It's only the passage of increased volume of the blood that causes the murmur. As such, the murmur of the ASD is quite weak and often may not be detectable by some physicians. I want you to know one other thing. This is interesting. Students quite often ask the question from me. At times, there may be also an audible, low-pitched murmur due to higher tricuspid flow in diastole. So, again, this goes back to the fact that we have a higher volume of blood in the right ventricle. So the major, again, not powerful, murmur is in ASD caused by passage of a higher volume of blood through the pulmonary valve. However, a higher volume of blood in the right ventricle also may regurge some of that blood back through the tricuspid, and that causes also another low-pitched murmur at times in the heart. So to summarize, heart murmurs are caused by normal flow through a stenotic valve or by high flow through a normal valve. For instance, flow through pulmonary valve in the ASD. Murmur of which valvular defect is similar to the murmur of ASD, and how do you distinguish the two from each other? Any ideas? The systolic murmur produced by ASD is due to increased flow through the pulmonic valve, and as such it resembles that of pulmonic stenosis, and both of them can cause systolic murmurs. However, the intensity of the murmur in ASD is much less pronounced. Additionally, ASD is presented with fixed split of the second heart sound. After Valsalva maneuver, the intensity of cardiac murmur of a patient is increased. This is most likely indicative of which of the following abnormalities: tricuspid regurg, atrial septal defect, mitral prolapse, mitral valve stenosis, or pulmonic valve stenosis. The answer is mitral valve prolapse. Let's make a generalization. Most murmurs decrease their intensities after Valsalva, that is, after decreased preload, with the exception of murmurs of hypertrophic cardiomyopathy and mitral valve prolapse. Again, as a general rule, increasing preload increases flow to the heart and increases intensity of almost all types of murmurs. In contrast, decreasing preload reduces intensity of almost all types of valvular murmurs. And I want you to lock in that information. That's why I'm repeating it. The only two notable exceptions to this rule, for the board's purposes, are mitral valve prolapse and hypertrophic cardiomyopathy. You are evaluating a patient with cardiac murmur. The patient is instructed to take a few rapid, deep breaths of amyl nitrite. You evaluated the intensity and the quality of his murmur about 20 seconds after the maneuver. Results show that there was a significant drop in the intensity of the murmur. Which of the following defects is the most likely cause of these findings? Later stage VSD, hypertrophic cardiomyopathy, aortic stenosis, mitral stenosis, or mitral regurg? You should know the answer. The answer is mitral regurg. Amyl nitrite again is a vasodilator. The maneuver causes an abrupt drop in the total peripheral resistance and decreases the afterload. As a result, the intensity of murmur of mitral regurg decreases. Remember, mitral regurg is a backflow murmur. As a result of drop in the afterload, blood can move forward through the aorta with more ease. This results in a more forward and less backward flow, hence the intensity of the murmur decreases. In the last scenario I said, amyl nitrite administration decreases the intensity of murmur in mitral regurg. However, earlier I said that HCM also causes dynamic mitral regurgitation. What happens to intensity of the murmur in HCM after amyl nitrite administration? Do you remember what I said earlier? If not, maybe this time this helps you to remember this high-yield fact for your examination. Amyl nitrite decreases afterload, increases ejection fraction, decreases the ventricular volume. Therefore, the outlet tract gets narrower in HOCM. As a result of flow through a narrow outlet tract, that is, as a result of increased outlet gradient, plus that famous Venturi effect that produces a suction effect. That suction effect produces a functional mitral insufficiency by dragging down and towards the outlet, the anterior leaflet of the mitral valve. And this produces a functional mitral insufficiency and increases the intensity of the murmur. Therefore, amyl nitrite increases the intensity of the murmur. What is the effect of increasing afterload on the intensity of the mitral insufficiency due to HOCM and mitral insufficiency due to rheumatic heart disease? You need to know this contrast. And as you can tell, this is a good subject matter for test makers to give you good questions about these topics. With HOCM, the intensity of the murmur goes down. In rheumatic mitral insufficiency, the intensity of the murmur increases. A variety of physiological maneuvers are used to evaluate and differentiate heart murmurs. Squatting is among the commonly used maneuvers, as we said earlier. Which of the following physiological findings commonly results from squatting? Increase in venous return to the right heart, increase in venous return to the left heart, increase in peripheral vascular resistance, reflex bradycardia, or all of the above? Actually, the answer is all of the above. Squatting, firstly, increases the venous return to the right heart, but then that blood goes to the lung and comes back to the left heart, so it then increases the left heart volume. So the timing is important. How long after the squatting you're listening to the heart murmurs? It also increases systemic blood pressure, and as a result, it is often accompanied by reflex bradycardia. Because when you increase the systemic pressure, you're going to reflexively increase the output of the vagus nerve onto the heart, and you're going to cause reflex bradycardia.